The next presentation is again by my co-chairman, Dr. Norbert Gleicher, and the title is Why Timing of Ovulation Induction Matters in Women with Low Functional Ovarian Reserve.
Thank you very much. And in a way, my second talk continues the larger theme of individualization of IVF cycle management. And I think that is really one of the overriding topics we should discuss these days in our field. Again, no direct conflicts here. I will be talking a little bit about historical perspectives again, motivation, why we even thought about investigating different timing of egg retrieval. Our investigations, as you will see, were initiated in women above age 43, but have since expanded to women with premature ovarian aging. In other words, younger women with low functional ovarian reserve. And we also, in the meanwhile, tried to determine what indeed are the best follicle sizes, lead follicle sizes, when to induce ovulation with HCG. And again, the conclusion of all of this will be that we really have to change from standardized protocols to individualized IVF protocols. So let's start with some historical perspectives. Now, the old-timers in the room, like me, remember that we started IVF cycles with inducing ovulation induction with HCG at follicle sizes usually at around 18 to 20 millimeters. In gonadotropin cycles and around 20 to 22 millimeters with clomid cycles. There was always a tradition in Europe to give HCG a little earlier than in the US, even though it's hard to track it in the literature, but that was at least my impression. On both sides of the Atlantic, there was always a general sense that older women should be retrieved a little earlier than younger women, but once again, I have never seen it really factually represented in the literature. So what got us interested in this subject? These are our center's 2010 to 2012 outcome data. And when you look here, you see that we did pretty well up to age 43 in our patients. But then something happened. And this was an observation we have made for many years. And so this was really the basic observation that led us into a series of investigations that I am going to discuss here today. Most of this work was done by Dr. Wu in our laboratory. He's no longer with us, but most of what I'm presenting to you was by him, and he has been the first author on 2 publications. So we wondered whether we, by molecular investigation of mature follicles at time of retrieval, could figure out what is going on in older women. And we started by investigating, in principle, women above age 43 as the primary study group, with control groups of young egg donors in the first row, with intermediate age patient group of infertility patient as a second control group, and group 3, where, as you can see, women above age 43, and this table demonstrate to you the patient characteristics as one would expect. The older the patients were, the higher their FSH, the lower their AMH, and you can see obviously distinct differences in the primary study group. You also can see the differences in clinical pregnancy rates. Now, one of the first hints of what we were to discover inside the follicles was the progesterone-estradiol ratio. And you can see a very significant difference in peripheral blood already in older patients. So this was a first hint that, that in the oldest patient group, there may be something going on suggesting early luteinization. So what were the studies? We obtained granulosa cells from egg retrievals, and in the first phase of the study looked at the molecular biology of those granulosa cells. We then also established cultures, and I will come to that in a second. So I will go pretty quickly through those studies because they are just presented in documentation that we, from various directions, found very convincing evidence for premature luteinization in older women. In other words, the luteinization of the follicle happened much earlier. So what you see here are studies of FSH and LH receptor and androgen receptor and estrogen receptor. And you see that the FSH receptor is down regulated in older women, while the LH receptor is upregulated, and this was confirmed by Western blot. Steroidogenic activity, again, evidence for premature luteinization. Aromatase was down-regulated, 17p-HSD down, and P450, as you see, was upregulated, again confirmed by Western blot. Apoptosis markers, no difference in granulosa cells, and again confirmed by Western blot, even though, as I will show you in a second, in cell culture we did find differences. So the conclusion was that we are seeing increased LHR expression, reduced FSHR expression, reduced aromatase expression, and all of this obviously supports that we are witnessing a premature luteinization of granulosa cells in women above age 43, even in comparison to infertile women who were younger. Now also, in support of that, the progesterone receptor confirmed this too, as you can see here. We now went into GC culture, where cells were evaluated days 1, 3, and 5, both in presence and absence of FSH. And once again, quickly, in absence of FSH, cell proliferation declined very rapidly. You can see you can see the differences in growing patterns, quite obviously no treatment, and with FSH treatment, clearly a very different growing pattern. Apoptosis, I told you earlier that in contrast to granulosa cells, in these cultured granulosa cells, older women did demonstrate much more rapid increase in apoptosis. So again, not very surprising, exactly what one would expect. FSH, thus at all ages, demonstrated expected positive effects on granulosa cell proliferation and apoptosis of cultured granulosa cells. But this effect is weaker in older women, and this obviously fits with the FSHR data I've shown you before. Now we looked at the impact of maternal aging on gene expression during the 5-day culture. On day 1, FSHR messenger RNA expression was low at all ages. It subsequently increased in younger, but it did not increase in older women. So once again, a significant difference. FSH in culture, like in the original cell studies, enhanced the response, but less so, once again, in older women. LHR, messenger RNA expression, increased, however, much faster in older women, again, supporting the notion of premature luteinization. And you see here the data. Though FSH in culture did not affect LHR expression, it did stimulate aromatase, messenger RNA, and protein expression. Finally, BCL2 gene expression decreased at all ages, but the fastest, once again, in older patients. Again, there was concurrence between protein expression by Western blot and PCR. FSH, by inhibiting this decline, does inhibit apoptosis, again, a finding that has been previously reported. In conclusion, both in vivo and in vitro culture of granulosa cells suggest that premature luteinization represents a central feature of the old follicle. And this, of course, raised now the question, is there anything we can do? We do not have a pharmacological way to intervene into premature luteinization, at least not yet. And therefore, what we decided to do is to change our retrieval protocols. And we decided to retrieve at smaller lead follicle sizes. And our initial protocol required HCG administration at 14 to 16 millimeters in those older women instead of the up to the 19 to 21 millimeters. This is the only thing we changed permanently. When we started the study, we also shortened the time interval between HCG and retrieval. We found that to have no effects, or if any effects, maybe even negative effects. So we went very quickly back to 34 to 36 hours. And we also, for a very short time period, transferred on day 2 rather than on day 3, and we reversed that as well because we did not see any effects. So the only change that we have maintained over the last 2 years is the earlier retrieval. And here, were the data published last year in the Journal of Endocrinology on early retrieval patients. We are still talking here about women above age 43. And you see here early retrieval group and the standard retrieval group, their characteristics. You can see they are really quite old. You see there is no big difference in egg numbers, and you see here that the pregnancies were mildly improved after early retrieval. Now, what is interesting, one of the concerns that we had was that if we go earlier, if we go earlier, we would get a large number of immature oocytes. And we did get, as you can see, more immature oocytes, but we started automatically overnight maturing. And we, at the same time, however, also quite significantly reduced the number of atretic oocytes in this group. And when you look at the number of good embryos, there was really absolutely no difference. So even though we went dramatically earlier, we still had the same number of embryos available for transfer. We also looked again at the molecular biology, and what you can see here is that indeed with earlier retrievals, we negated a big part of the molecular evidence for premature luteinization. Not completely, but to quite significant degrees. So going early indeed allowed us to retrieve oocytes before the premature luteinization process in the follicle had fully developed. This is the paper that was published last year, and as I mentioned, Dr. Wu did most of the work. Now, this raised the question whether the same observation could also be made in women who have low functional ovarian reserve at younger ages. We call these patients women with premature ovarian aging. And so we did a follow-up study, again with Dr. Wu as the lead author, where we looked at younger women, and you can see the ages here, with high FSH, and as you can see, quite low AMH values. And we basically repeated the same study, and you once again can see that we got significantly fewer atretic oocytes. We actually, here in this patient population, saw no difference in immature oocytes. And I want you to look in this patient population at the amazing difference in clinical pregnancy rates. So in this population, the effect of early retrieval was even more pronounced than in the older patient population. And that actually should not surprise, because in younger patients, we in general get better results than in women above age 43. And once again, we found that also in these women with premature ovarian aging, the early retrievals normalized the molecular profile in the follicles. And that brought us to the final question, which was, you may recall that I told you that we were retrieving between 14 and 16 millimeters in those patients. And the final question we asked, since that was an arbitrary decision, have we made the right size choice for HCG administration? And so in the third phase of this study, we looked at 3 patient groups: very early retrieval, and standard retrieval. And you see that this was, again, quite an old patient population with quite low ovarian reserve. And we defined very early retrieval as 14 to 16, as early retrieval as 16 to 18, and standard retrieval was our standard retrieval at 18 to 22. And what you can see here, that mature oocytes in the very early retrieval group and in the standard retrieval group were similar, but we had more in the early retrieval group, 16 to 18. And when we go all the way down to high-quality embryos, you can see a dramatic difference in high-quality embryos in the 16 to 18 millimeter, while if we went earlier or standard, they were both equally bad. And so, like many times in biology, there is a range, and if we are too late, it's bad, and if we are too early, it's bad, probably because here plasma maturation is out of sync. And so we now are routinely giving HCG at 16 to 18 millimeters in patients with low functional ovarian reserve. And obviously all of this was also reflected in the pregnancy rates. And once again, it's interesting to see that the pregnancy rates in very early retrievals and in standard retrievals were very similar, while in this range we had a significantly improved clinical pregnancy rate. So again, molecular studies of the follicles revealed that in that early retrieval group, we had significant improvement, even though, interestingly enough, signs of luteinization were even lower in the very early retrieval group. So in other words, even if it just comes to the signs of premature luteinization, even earlier retrieval would probably be better, but very likely the maturity of the plasma negates that, and therefore with earlier retrieval we are not getting good results. So what's the conclusion of all of this? The conclusion of all of this is that I think we have entered the time of individualization of patient care at many, many different levels, with the time of HCG administration just being one individualization. Thank you very much.